Good morning, good evening, good afternoon, everybody. I'm Benedict Walter from the Secretariat of the Network for Improving Quality of Care for Maternal, Newborn and Child Health. Welcome to this webinar on Use Data for Action, the fifth in a series on transforming care for small and sick newborns, organized by UNICEF and the World Health Organization in collaboration with the Network for Improving Quality of Care for MNCH. You will see that you are all muted on entry during this webinar. However, we want you to engage with the speakers, so please type your question and your comment in the chat box that you will see in the bottom right corner of your screen while the presenter are going through their presentation. We will read your question in the second half of this webinar, and the speakers will have a chance to answer it. We will send you also a link with the recording of this session, as well as all of the presentation tomorrow. I would like now to introduce you to Dr. Onela Linchetto, who will facilitate to this session. She is a Senior Medical Officer for Newborn Health at the World Health Organization in Geneva, and a lead editor of the Survive and Thrive report. Onela, over to you.
Good morning, good afternoon, good evening. Welcome to the fifth webinar on the report to Survive and Thrive, Transforming Care for a Very Small and Sick Newborn. Today we will discuss the chapter 5, which is focusing on the use of data for action. And it's particularly important now that where we want to know much accelerate progress on advanced newborn health and reducing stillbirths, but also understanding better what is the impact of COVID-19 in this specific population group. So the importance of data on that. Next slides, and I would like to introduce the agenda of today's session and the facilitator. So we will start with the presentation on the key findings by Dr. Louisa Tinade. She is a pediatrician and obstetrician and assistant professor at the London School of Hygiene and Tropical Medicine. And then we will have a presentation on the experience with kangaroo mother care and use of data in Malawi. The presentation will be done by Mr. Kondani Shabula, who works for Save the Children at the Malawi country office. He's an expert on monitoring evaluation. And then we will have also a short presentation on the type of data required to measure the impact of family-centered care on newborns. So this will be done by Silke Mader, who is the chairwoman of the executive board and co-founder of the European Foundation for the Care on Newborn Infants. And then I will, as usually, I will close with a few slides on, in this case, on COVID, and today we will focus on the data to measure the indirect effects of COVID-19 on newborns. And then at the end of the session will be with the question and answers as usual. So I would like to then pass the floor to Dr. Louisa Tinade for a session. Over to you, Tina.
Much, Onela. And good morning, good afternoon, good evening to everyone. Thank you very much for joining the webinar this morning. And this report was a collaborative report by many agencies, as you can see from the logos on this slide. Today, we're focusing on using data for action for small and sick newborn babies. Every country has data that can be used now to drive action. And we've seen that illustrated in the webinars so far in this series. But at this time of COVID-19 disease pandemic, more than ever, we see our need for data and yet how fragile our data systems are. There are many opportunities to improve data for small and sick newborns, data quality and availability. Gaps in high priority data must be closed to end preventable deaths, to ensure health and well-being and change how small and sick newborns are cared for. In the series of webinars so far, we've been reminded that neonatal mortality represents about half of all under 5 deaths. Small and sick newborns require special care to survive and thrive. Among the 100 World Health Organization core health indicators, only one is specific for small and sick newborns, the low birth weight rate. But policymakers need reliable, specific data for small and sick newborns to track progress towards the ambitious 2030 targets. Firstly, what data do we have that we can use now to drive action? This data pyramid illustrates which data are needed for small and sick newborns at different levels of the health system. Each circle represents a data point. Family and community are at the base or the foundation of the pyramid as we think of a family-centered approach. The different colored circles represent all the different types of data for each individual child. Health workers using data for day-to-day clinical decisions and communicating information to families about their children. But the health system can't cope with all that data. So as we move up the pyramid, some of that data moves up to facility, subnational, national level, as shown by examples in the table on the right. The data points in yellow at the center, core or common indicators, are ones that are needed at the national and global level for tracking. And you can see there are lots of two-way arrows between the data points and down the side of the pyramid between the levels of the health system to represent how important feedback is to improve data quality. Different types of indicators are used for different purposes. The Every Newborn Action Plan, strategic objective number 5, is to transform measurement. This table shows the Every Newborn Action Plan indicators. In the first column, the current status heat mapped with traffic light colors. The second column are the type of indicators. The third column, the core indicators for every newborn, and the fourth column, the additional indicators. Indicators specific for small and sick newborns are in black font. And you can see if the background is shaded in a gray color, those are the ones that are not yet tracked at national or global level. And we'll now look at each of those type of indicators in turn. Firstly, impact indicators, which are used to measure results and track progress towards national global goals and identify equity gaps. We have neonatal mortality rate, which can be stratified by sex and by birth weight groups for small and sick newborns. But more specific data are needed, particularly gestational age, and perhaps the biggest gap is for data to help follow up small and sick newborn survivors after inpatient care, who, as we heard in the last webinar in this series, are at high risk of developmental and nutritional poor outcomes. The second type of indicator we'll look at are coverage and quality of care indicators, which are used to plan and improve services. Coverage indicators measure the proportion of small and sick newborns who receive the care they need. Quality of care indicators measure provision and experience of care. The data we have that we are using now includes contact coverage, typically from nationally representative population-based surveys. But increasingly, content coverage is needed, and that's more and more being captured by routine health management information systems, for example, interventions that newborns are receiving in health facilities. But more data are needed. Quality of care indicators need refining, standardizing, and validation. And a topic that's very important right now during the COVID-19 virus pandemic is how can we measure unnecessary separation of babies from their mothers? If we knew how to do that better, it would be helping us right now to keep mums and babies together as the world battles this pandemic. In a few minutes, as you've heard, we're going to hear from Kondwani Chavula to share lessons learned from strengthening kangaroo mother care measurement in Malawi. And after Kondwani's presented, we'll be hearing from Silke Mada, sharing with us how measurement is important to engage parent and communities. Finally, we'll turn to measurement of inputs based on some of the health system building blocks. Firstly, service readiness measurement. Periodic standardized health facility assessments measure across 5 domains: facility infrastructure, health technologies, care guidelines, human resources, and training and routine practices. But as you'll see in the next slide, these need further standardization to capture everything that's needed for small and sick newborns. In this table, the three service readiness tools that are commonly used are shown in the columns on the right: the SPA, the SARA, and the EMONC tool. Towards the bottom of the table, the boxes are green, showing how many of those 5 domains these tools capture. So for essential or immediate newborn care, towards the bottom, you can see these tools are capturing some of these interventions that are needed for small and sick newborns. But as the complexity of the care increases at the top of the table, these tools capture less of those 5 domains. And on the 5th line, effective phototherapy, which is a commonly used intervention, isn't yet captured by any of them. Secondly, health management information systems are needed to guide action at all levels within the health system. We've already looked at the data pyramid, and the rapid expansion of electronic platforms has potential to unify and align traditionally fragmented information systems. We've seen also how core and common newborn indicators specific for small and sick newborns have been taken up. But we need to focus on data quality using feedback loops. We also need data that track individual newborns longitudinally, linking them to their mothers and also their own life course. Standardized neonatal inpatient records are needed, as well as implementation research designed to strengthen the relationship of data systems and the use of data. In India, we have an example that's shared in the chapter of real-time monitoring of newborn care units. Each year in India, more than 1 million newborns are cared for in special newborn care units. Data is used for accountability and action by the National Health Mission's monitoring system to assess the performance of the unit, to measure impact, mortality rates. There was a 22.5% reduction measured between 2011 and 2016. But also the data is used for individual longitudinal follow-up after discharge. And in the second seminar later today, we'll be hearing from Dr. Gagan Gupta in more detail about this data for action in India. Thirdly, we need data for health workforce measurement to shape policies and plan adequate numbers of suitably trained health workers to provide inpatient care. This data is limited at the moment, but we need robust data here to track competencies, staffing ratios, recruitment, deployment, rotation, and migration patterns. Importantly, we also need to learn how to measure the experience of health workers caring for small and sick newborns, and how we can measure the health system's capacity to support caregivers. Then finally, for inputs, we of course need data on health systems finance measurement to plan service delivery, to ensure access, determine who's paying for universal health coverage, and track spending for accountability. And fifthly, measurement regarding leadership and governance. And just as an example, Sustainable Development Goal 17, Revitalize Global Partnership for Sustainable Development, has a specific data target to increase availability of high quality, timely, and reliable data. So we've heard what data do we have that we can use now, but of course there are many opportunities to improve the use of data. We'll look at 3. Firstly, civil registration and vital statistics. Small babies are low birth weight, and this graph illustrates how much we know about birth weight from routine data. There are 4 groupings: global, least developed countries, Southern Asia, Sub-Saharan Africa. In dark red are the percentage of births that take place in facilities. In blue, the percentage of births that are registered in those groups. And in yellow, the percentage of birth weight data that's available in routine systems. Let's focus on the least developed country, the second block of bars. You can see that more than 50% of babies are born in facilities, but 12.8% less babies get registered, and 46.5% less babies have birth weight data available in routine systems. So this is the sort of data that needs improving. These babies are born in facilities, often weighed, but we can't use that data to track low birth weight rate at a national or global level yet. Secondly, maternal and perinatal death surveillance and response. This continuous action and surveillance system identifies modifiable factors to implement actionable recommendations for change. But currently, there's a gap between policy and practice. Policy commitments stronger for mothers than for newborns. And in the second seminar later today, we'll be hearing from Dr. Alex Manu about implementation of MPDSR in Namibia. And then thirdly, using data to improve quality of care. We all know that counting alone is not sufficient to change practices. Data needs to be used for action to implement solutions. And the Quality of Care Network's monitoring framework guides quality improvement implementations and specifically the use of data to track outcomes. So gaps in data must be closed to transform care so all newborns can survive and thrive. This is especially true for babies who are born as the most vulnerable in fragile settings, and yet we have the least health-related data available for them. For universal health coverage, we need to increase data availability in humanitarian settings, and especially link that data with stable settings, even the same host communities. The gaps in data must be closed to transform care so all newborns can survive and thrive. Priority data to close those gaps for action for small and sick newborns. For them to survive, we need to use HMIS integrated coverage and quality of care indicators. We need to be able to link individual standardized clinical records for newborns to comparable core data sets and standardized service readiness tools to include small and sick newborns. Secondly, for small and sick newborns to thrive, priority is to standardize indicators linked to child development and nutrition for high-risk small and sick newborn survivors. And finally, the priority to transform would include improving metrics for small and sick newborns in all settings, including humanitarian, and especially to be able to measure experience of care for newborns' families and healthcare providers. I'd like to acknowledge the co-authors on this chapter listed there, the managing editors, and the people who helped with the PowerPoint slides and the graphics. And as we mentioned earlier, there were more than 94 authors involved in this report, and all are appreciated. I'd like to now hand over to Kondwani Chavula, who's going to share with us their experience of kangaroo mother care measurement in Malawi.
Thanks very much. Good morning, good afternoon, good evening, all of you. So I'll be talking through what we did actually to improve availability and quality of routine data for newborns in Malawi. So the focus mainly is on kangaroo mother care. Next. So since 2005, Malawi scaled up facility-based kangaroo mother care. However, in the absence of a national system of standardized indicators, registers, and reports, routine data have been limited and of poor quality. So in 2014, the Malawi Reproductive Health Directorate and the Central Monitoring and Evaluation Department, with support from Save the Children, began a four-phase process to develop a national routine reporting system for facility-based KMC with a simple user-friendly register and reporting form. So mainly the four phases involved prioritizing core indicators with data elements. We saw a reduction from 32 to 8. Then phase two, redesigning a standard pre-coded register linked to a monthly reporting form with instructions. Then we did a pilot testing in 21 facilities across Malawi. Finally, based on the feedback that was received, the tools were actually revised, then approved by the ministry in 2015. Next slide, please. So 8 data elements and 5 core indicators were incorporated into the Malawi DHIS tool. So the 5 core indicators are KMC initiation rate, KMC referral completion rate, survival to facility discharge, death before facility discharge, left against medical advice. So to generate these core indicators, we actually had to input 8 data elements into DHIS2. 6 data elements were being captured at facilities with inpatient KMC, and 2 data elements being captured at facilities without inpatient KMC. Next, please. So after we developed the register and the reporting tool, there was the national training and orientation that led to improved reporting. So this graph that you see is actually showing improvement of classification of babies on type of KMC based on birth weights, those that were on a facility-based kangaroo mother care, and those that were on ambulatory KMC. So the old register did actually not allow capture of KMC, and there wasn't like a proper categorization, as we can see in 2014, where there was an estimation of babies being classified as belonging to facility-based KMC. But with the improvements and the revisions that took place in the register, we saw improvements over time, going down to like 2017, where now the hospital staff were actually able to categorize babies properly based on the type of KMC, looking at the birth weight that the birth category that they belong to. Next slide, please. So this slide, though it's a little bit hard to see, it's actually it represents a summary of data for the same. So this data is actually extracted from DHIS2, and within Save the Children, we actually analyze it and work together with the ministry to look at what's actually happening in the system. So this data is actually highlighting improved reporting of KMC by hospitals. However, it masks a very important gap in data completeness and timeliness. But on the overall, what we see is that the results are not actually uniform, and there is a wide variation by districts. And the levels of identification and initiation of babies on KMC is actually below the desired levels. So we also look at data at status at discharge, but this data actually has to be interpreted with caution, because we actually don't have information related to birth weights and information related to other complications that can actually be analyzed further to actually have a clear picture in terms of the status at discharge. Next slide, please. So what we learned so far from this process is that leadership from government and early involvement of end users actually helps to gain approval and ensure ownership. Then prioritization of indicators and data elements that are actually suitable for routine reporting minimizes reporting issues and actually helps to improve data quality. Unlike having like different multiple registers, as was the case before, we're actually having like a different data elements being captured in multiple registers. Then substantial and sustained additional investments is actually required. Like in our case, it actually took us quite some time to have the indicators and data tools customized in DHIS2. And we also actually need human resource at all levels, the district and including the facility level. Then also on the overall, if there is also improved collaboration across partners, actually we see that it becomes a little bit easier to work through the system to improve data quality and use. So for further details about the process that we actually had to go through, you can actually visit the Healthy Newborn Network.org. So I'll actually hand over now to second mother.
Next slide, please. Good morning, good afternoon, good evening to everybody. I would like to share with you also the measuring and the importance of data from a parents and community engagement. Measuring the family experience of care is key to a family-centered care approach. The death or the illness of a newborn is a major family crisis. Good communication and the sharing of meaningful information between families and healthcare providers is crucial for a high quality care. And if we want that these babies not only survive, but also thrive, it is important to also take care of the information what parents can provide as data. Next slide, please. I would like to share with you my own story, what I had 23 years ago. Of course, in a high-level income country, but nevertheless at this time in a very challenging situation. My children were born in 25 weeks of gestation. I had a severe preeclampsia and HELLP syndrome, and our son Lucas had 550 grams, Lena only 290 grams, and I had a resuscitation. It was not clear if one of us survived. So to collect data really from parents and how they experienced the NICU care, how much they were supported. I lost, for example, all my milk because there was not support given. So knowing that this is key in this time frame of taking care of the children or us as parents, it really matters later in life. So this data, what I have established now, this organization can help others to improve the care of our children in the future, not only in high income countries, it's very important for low and middle income countries. Next slide, please. So assessment should take place at a time and place where it is convenient for the parents, and it should be a part of the process to support and guide their growth as a main caregiver in the unit. So this assessment of parent knowledge, the attitudes and the beliefs, what parents believe for their baby and how they feel as parents in this inpatient care, but also afterwards, it's important to really implement the family-centered care approach. So program assessment and using evidence-based family-centered care guidelines can really improve the quality of family-centered care. But I always want to stress also the long-term outcome, because we have enough data now to know that when the parents feel as a parent, they go home self-confident and the baby later has a better outcome. And this is already evidence proven. So therefore, our experience in the past helped to bring this family-centered care to a level where it is more and more implemented in the countries across the world. So next slide, please. There are tools to measure the parents and community engagement already for care, for the small and sick newborns community yet. Fewer of them are already standardized and validated. Family-centered care tools for neonatal units also exist, with options specific to low and middle income countries. Such tools use staff and family surveys and benchmark reports to assess provider perceptions and parent satisfactions at discharge. And when it goes to satisfaction, again, it's important to have self-confident parents, because they take care of these babies after discharge, and they have to understand how to treat this baby at home, how to take care of this baby at home. Even in low and middle income countries, it's very important because they cannot go back to the hospitals all the time. At a social and policy level, some of the toolkits offer suggestions to monitor advocacy activities and results. And when you see which kind of tools can measure, it's, for example, the parent and the community engagement in the care of small and sick newborns. It could be, for example, a self-help group or a peer group where parents can ask other already veteran parents to support them. So it is important that we ask for the satisfaction to improve for the next generation of parents and preemies in this case. So therefore, it's important to really ask what can be done better. And this needs to be measured to be better in the future. Next slide, please. So what are potential questions to measure the type of support to receive? Are there, for example, any, are there already any measurements taken for parents and caregivers to develop appropriate skills to care for their baby in the facility, or for example after discharge, or positioning the baby, for example, or to talk to the baby, to sing for the baby? What can be offered for the parents? Do they report a positive care experience in the facility, and if not, why not? What can be improved for the future? Do they share information regarding any situation of disrespect or abuse that you can feel as a parent? If you not feel as a parent, you maybe have later on bonding problems. That's something what we really have to take into account. And are there facilities to help parents to be close with their newborn? That means, is there enough space or room for staying overnight to not separate the parents from the baby? Are there toilets or showers or restrooms available? And if we want to have breastfeeding really implemented, we have to think about providing food and something to drink for the mother, or that family members can bring it if this is not possible to provide this from the hospital. Next slide, please. So when it goes really to think into this topic, what can be provided, how can you support parents? Of course, we have to think about appropriate education and materials for these parents. It can be digital materials, it can be printed materials, or it can be also oral informations what you can provide for this parents. So, but is this really given, and from whom and how often, so that we can measure if this is successful or not? Was this newborn separated from their mother and without explanations, and what consequences had it, especially when we talk about breastfeeding, bonding, kangaroo care? That's something what we have to take into account and needs to be measured. Are there community groups like peer groups, support groups, any kind of nursing or caregiver groups where parents get support? And how can we bring these parents to this group? So how can we facilitate this communication, that this exists and where to find it? Slide. Next slide, please. So these are the things where I think it's important to take care that parents and the information what parents receive and what parents needs to be measured, and the data have to be collected to improve the care for the future. Not only if a baby survives is important, also that the baby can thrive. And so therefore it's important how we treat and how we take care of the parents because this baby is going home to this family. So which kind of information parents really have received after they leave the hospital or at discharge, to be in the end independent and self-confident to take care of this tiny baby. Are these community level services really informed about preterm infants, small and sick newborns, so that they can take care afterwards proper of these babies? Where our support is given about mental health issues after discharge, or when a baby passed away. So any kind of information for grieving families is important. And as being a parent of having lost once, and one survived and is now 23 years old and fighting for really a proper follow-up in our community of parents, this is something that comes from my deepest heart, and we have to take care that these babies not only survive, they should thrive and should have a happy and a healthy life. So I would like now to hand over to Dr. Ornella Lincetto from the WHO, the Senior Medical Officer in Newborn Health. Thank you.
Ornella, you're muted.
Thank you very much. So we heard how important monitoring is and that all countries are collecting data. And actually we are using available data also to understand the impact of COVID-19 on newborns and families. So as mentioned in previous webinars of this series, newborns are not basically they are a lower risk of COVID-19 compared with other groups, but they are population groups, but they are at risk from indirect effects and basically from the disruption of services that the COVID pandemic has created. So you can see in the slides a list of countries on the left side, and the service, maternal, neonatal, and child services on the vertical side. And it's not necessary to go to the detail, but you can see a lot of yellow and red, which represent actually the disruption of services. And many countries, as you can see, already in June were affected in their maternal and reproductive and child health services. So what is important is how can we measure this disruption? And how can we measure the causes of disruption of services and the impact on specifically in our case on newborns? Next slide. There are a number of factors that are causing this disruption that are not only on health system domain, but are also a mix of government and individual decisions. And from the survey that has been conducted in the previous months, you can see that a lot, 79% in 79% of cases, there was a decrease in outpatient volume due to patients non-presenting. So that was individual case, but also difficulties on because of, I don't know what is happening on the slides. I see gray on top. Government, but also due to, transport and restrictions due to the policy related to protection for the entire population from COVID, and other factors that are also entering in the system, like, for example, lack of services, like limited access to services, limited access to supplies or to human resources, or even the services not to be available at all. Next. So next slide, please. So but we are also facing in terms of COVID-19 a number of measurement challenges for if you think about newborns. First of all, we heard from the presentation that the lower middle income countries don't have a strong monitoring system for newborn care. And from the INAP progress report, the most recent one, you can see a few data from the 19 countries that are reporting for the INAP. Barely 41% have birth registration in their health management information system. Only 22% have a perinatal death review indicator in their health management information system. Less than 50% of countries have developed a perinatal death review response system. So there are also limitations in terms of indicators for assessing impact, quality, equity, and so on. So this, of course, has posed some a big challenge if you want to know both the direct as well as indirect effects of COVID-19 on newborns. On top of that, it's a new disease, so we don't know much, or it's only partially understood what is the effect of COVID during pregnancy and on neonatal outcomes specifically. So, and another challenge is that the indirect effects depend on many factors that require measurement, and some of them are not typically factors, health system factors. So we have to work also with other, sectors in order to be able to collect data. Next slide, please. And so what has been done, what are we doing in order to better understand both COVID and its impact in the population groups, including the newborns? So WHO is working with a number of partners. We have set up a roadmap already in February to develop the research that is required to understand the disease. We are tracking a number of, more than 700 trials are underway. We are using the results of these trials to together with, in order to provide advice, to develop the recommendations on both the clinical care as well as the programmatic recommendations through independent panels that we have set up. There is a solidarity trial. I think everybody heard about this, that has been launched by WHO together with partners, is involving already more than 100 countries, and this was in May. Now there are, I think, 3,000 patients already enrolled. And then we have the Tool Accelerator, which is another initiative that, again, in partnership with many organizations, that is aiming at making more, developing and make developing faster and make available the supplies, medicaments, vaccines, etc., in order to address the disease. And next slide is more focusing on what is the next, is more on the efforts that are ongoing in terms of measuring and modeling. So for our specific area of work, the newborns, we have, of course, the country reports, and we analyze these country reports and the data that we collect are transformed and are analyzed and transformed in situation reports, and the dashboard that you can access in WHO website. And then we have also the rapid surveys conducted by UNICEF support that are looking at the disruption of services and their causes. We have the research studies, as I mentioned, and specifically would like to mention the cohort studies of pregnant women that are followed. These women are followed to better understand the impact of the virus infection on pregnancy outcomes, both in terms of fetal outcomes and neonatal outcomes. And we are also conducting just starting clinical characterization studies to better understand the disease on the newborn, because it's true that so far we are saying the newborns are not much affected, but also they've not been studied very much. So it's important to have a clear understanding of the clinical characterization of the disease in the newborn in order to differentiate it from other neonatal conditions. And then there are the modeling, because this is also important to create scenarios and to try to model the impact, the indirect effects particularly. So this has been done looking at the indirect effects of COVID-19 on maternal, neonatal, and child health services using the LIST tool. This is done by the Johns Hopkins School of Public Health and published already, and it's very worrisome. In fact, with just a small reduction in coverage of maternal, neonatal, and child health services, we can have a very big negative impact in terms of mortality on mothers and newborns and children. And there are also efforts on conducting simulation of COVID-19 risk in different scenarios by the IDM, and this is to understand again the indirect effects and to develop measures in order to address them. We are also tracking public health and social measures because this is important, again, both in terms of understanding what is happening and but especially in for the future to try to see what can be done in order to improving again access to essential services and finding alternatives also to make these services more accessible. So in the context of the epidemic. So again, so there are many efforts that are going both in terms of measuring and modeling, but at the same time, I think for us, work on neonatal health is extremely important to continue to strengthen measurement of newborn indicators in line with the enough milestones, because we need to continue to measure, for example, neonatal every newborn and basically neonatal deaths in order, but also gestational age, birth weight, etc., in order to better understand the direct and indirect effects on COVID. We need to continue to measure coverage, and coverage is important for us in general to move forward with the reduction of neonatal mortality and stillbirths, but also to understand the indirect impact of COVID on the coverage. And then, of course, we need to continue to work and strengthen the measurement of quality of care, because this is very important from the point of view of course, the individual newborns, but as well as for their families. So the perception of and the perspective of both families as well as care providers is very important to be measured in this context, in the context of COVID and in general, of course, for improving the services. So I close here, and I would like to hand over to Bene for the discussion. Thank you very much.
Thank you very much, Ornella. We have a few questions that came through the chat box. Please keep sending them and address them to all panelists. So I have a cluster of questions for Silke. One from Georgina Seymour, asking how can health worker in facility measure feelings of parents to improve experience of care?
I guess it's important but there are already a couple of assessments available where I can maybe afterwards send to the WHO team and UNICEF, because this is something what you can use. So you can, for example, ask if they are overwhelmed and in which situation they are overwhelmed, and what stressed them enormously. And so, for example, in a very luxury way, what we have here is to find, for example, a parking place in front of a hospital, because when you imagine a town like New York where you not find a parking place and you go around for 2 hours and just seeing your baby, that stress you a lot. And so in other cases, for example, it could be that you not get enough food, not enough to drink, not having access 24/7 to your child, and that increases your heartbeat. It can be you ask the feeling, but you also can measure, for example, stress levels, what parents really overwhelms, and so and what can help them. So it's not only the negative part, it's also what, for example, could be helpful, having their place to sit, having their food or something to drink to reduce the stress. It can be also very positive issue. And so only saying, for example, that you are sad that the baby passed away helps you, that all you see that these people also are sad that your baby passed away. That helps me still today to think that the nurses and doctors were also sad that my daughter Lena died. So there are a couple of things which can be measured and can be in the end help to improve the outcome, especially of the whole family.
Thank you very much, Silke. Another question for you. Could you share the link to access tools to measure family-centered care? And we can send this to all participants in that case.
Yes, definitely, I can do that.
And the third question, and I think it's for you, I'm not entirely sure. What kind of data can we translate and utilize from the home-based records in terms of quality of care indicator?
Oh, I'm not sure if 100%.
Louise.
That's for Louise. Okay, sorry, Louise, do you have an answer to that?
Yeah, thanks very much. That is a very good question. And we haven't mentioned today, but the Community of Practice for Small and Sick Newborns launched last week. And in fact, it was there again that actually developing measurement for families is really a priority, and that interest in taking that forward. So I don't have a specific answer to home-based records, but I think it's a brilliant question that we need to explore further, and maybe that community of practice can facilitate that going forward. Thanks.
Thank you. Another question for you, Louise, from Joy Lone. The table of every newborn indicators from 2014 showed a lot of gaps. Has any progress been made to validate this, especially in routine systems?
Yeah, thanks, Joy. So there's been lots of work, including work that we've been involved in at the London School, to validate coverage indicators in facilities and look for the best measuring them. So those results are just about to come out. So yeah, there's still work to be done to improve coverage measurement from facilities, but we're excited for the potential to close the data gap by using those coverage measurements from facility and with feedback loops to see that data strengthen. The study is called the EN Birth Study, and yeah, we look forward to sharing those results with the wider audience later. Thank you.
Thank you. Two questions for Kondwani. One from Mindenburg asking if KMC in Malawi is for all babies.
Thank you very much. So KMC in Malawi is actually for all low birth weight babies. So there's actually a weight category for which like a baby can be classified either to be on KMC. So for those that are like less than 2,500 grams, they can all be put on KMC, but then the categorization in terms of whether they are put on facility-based KMC or whether they are actually put on ambulatory KMC, where they actually initiated on KMC, and then the mother is actually sent home with the baby. Then they just come up for like a follow-up visit. So for all babies that are like low birth weight, yes, KMC is actually for them. But the only challenge is that identification and actually initiating of those babies on KMC, it is what is now a little bit problematic in Malawi.
Thank you. Another question for you, Kondwani. How does the government of Malawi use the data to inform planning?
Thank you very much for that question. So ideally, I'll talk from two perspectives. One from what we see, like say from partner point of view, like Save the Children, how data can be used. So I showed a slide where we actually get data from the system and analyze it. Then once we do analyze, we actually get in touch with the people at the ministry and actually discuss that data. But what we want to actually see on the overall picture is that data actually has to be used from the lower level, not from top to bottom, but from bottom to now top, which is actually problematic. So there are like actually steps that are being taken to ensure that data use is actually being used at all levels. Just like there is currently a development of an app that's been developed, which you can actually it actually presents dashboards. It's a mobile app. So just to try to make sure that data is being used actually from the lower level, not just data being aggregated in the system.
Thank you, Kondwani. I also had a comment from Joy Lone about a summit that is taking place at the moment, specifically on the effect of COVID on newborn. Ornella, would you talk to this, please? You on mute.
Yes, there is a summit organized by the Partnership for Maternal, Neonatal and Child Health. It's taking place today and tomorrow. Global Summit is on the COVID-19. It's called Lives in the Balance, and is looking at the effects. I mean, thinking what happened so far, what has happened so far with the COVID pandemic and the effects particularly on our vulnerable groups, women and children, adolescents, and what can be done for in the next months to what we learned, what can be done to work better in this area. And then there are several sessions, so it will be today and tomorrow. And the session, apparently there are 1,600 people registered on the neonatal session that we are organizing tomorrow.
Thank you. Thank you very much. This is all the questions I have received for the panelists so far. So I will hand over to Ornella to close down. Please take note of the slides that you're seeing at the moment with all the link to register for the next session. And Ornella, over to you.
I would like to thank all of you for your participation and both the participants and the speakers. And we will, I think this monitoring is not is a very important topic. Without having the data, it's very difficult to continue to advocate, and it's difficult to how to say, improve our programs. So I really, I mean, it's very close to my heart, this particularly now that we have the COVID-19 pandemic, is very close to my heart to be able to monitor what is happening with every single newborn. And for the next webinar, I would like to also encourage you to attend the next one, which will be in 2 weeks on the 15th of July. Then there we will talk about the actions that are needed and what can be done to reach the targets by 2030. Thank you very much and have a very good day.
Thank you and goodbye.